I'm going to talk a little bit about ECC here at the Ralph. Just to be aware, our emergency and critical care department is also an intensive care unit. So I'm going to be using the words ECC and ICU interchangeably. The ICU side of things here at the Ralph is that we take care of the most critical patients in the hospital, and that is for any department. And the ECC side of things is that we triage sort of non-clinically specific emergencies. We stabilise them, and then we may transfer them to different departments that are more appropriate. So it's really varied. Every single day in the ICU department is different. I've never been bored for one moment here. We're a really close-knit department, and I'm going to talk a little bit through sort of what we would do in a case like Ralph and sort of our general day-to-day in the ICU department. Okay, so we've got Ralph Ralphison. So as Becky said, his family vet has referred Ralph to the ECC department for lethargy, pale mucous membranes, general sort of weakness. He's got an increased heart rate, and he's got pale mucous membranes. He's a known diabetic, which is being managed with insulin. Often when a patient appears quite critically to a family vet, they refer to us because, especially if they've got an underlying condition, that's because management of the case can be quite specific. It can be a little bit more delicate. Obviously, we've got a lot of expertise from different departments here, and we've also got a lot of quite advanced monitoring systems here, as well as diagnostics. So I'm going to talk to you exactly what we're going to do with Ralph. There we go. So I'm going to talk generally about what we do sort of when we triage a patient who comes to us in an emergency. As nurses, we're responsible for performing the triage. We have a station set up in ICU, always ready with a crash table, just in the event of an emergency. We always have a multi-parameter and everything set up so we can get some vital readings from Ralph. So our job in the ECC department, as the sort of the first line of care for Ralph, is we're going to see how critical his condition is. We're going to try and get a really good idea of what's going on with him internally, and find out the best way to stabilise him and go from there. So the things we look for in every emergency, sort of the basics that everyone knows, is their ABC, airway, breathing, circulation. We've had patients come from their referring vets to us relatively stable at the vets, and they arrive to us sort of peri-arrest. So sometimes with these patients things can change very quickly. We've also had patients referred to us, say for something seemingly stable, and they've actually turned up with an undetected pneumothorax. So we've had to really jump to action very quickly. So we generally just have to be prepared for anything. So that's why even with, if we think a stable patient is coming down, we have everything set up, and we make sure we check everything from the basics. We also have to look at the mentation of the patient. So when they arrive, we kind of quickly assess, you know, are they conscious? Are they lethargic? Are they distressed? Some patients who arrive quite stable, but they're very distressed, we may just pop them in a kennel for a little bit, allow them to settle in, and that's maybe the best thing for the patient at that point. So when Ralph arrives to us here, he's very lethargic. We take a table out to the car, we wheel him in, take him straight into the ICU and get him triaged fairly rapidly. So the usual basic, apart from checking that, you know, he's alive, he's breathing, he's okay, we check the basic parameters. So we check the heart rate, respiration rate, respiratory effort, mucous membranes, capillary refill time. We check an SpO2, and we can give oxygen if we need to. We've got plenty of oxygen around the ICU. We check a temperature, so the really basic things in a general TPR. We also look for pulses and pulse quality. This is really important as nurses, that we sort of understand the difference. We get used to feeling pulses so we can feel how different they are. We also look for IV access. A lot of patients are sent to us with an IV in. That can be really helpful in the event of an emergency. If they're very debilitated, we may have to get an IV in pretty sharpish so we can give some emergency drugs. And pain. Do we need to give analgesia? We have patients come to us who have been in an RTA. They can be in quite severe pain when they come to us. So also having an IV in helps deliver that analgesia quickly. We also always take blood gas reading very quickly, and I will talk a little bit more about that in a sec. So we'll go over the basic ones first. So the heart rate. So if the patient allows, we always put an ECG on the patients. And this allows us to sort of see the heart rate live, beat by minute, beat by beat, not beat by minute, beat by beat. And it also allows us to do a basic assessment for any arrhythmias. So we're not the experts in cardiology, that's the cardiology department who's going to talk next to you. But we can have a little look and see if we see anything unusual. And if we do, then we can call on our friends in cardiology and we can ask them to assess the patient. But having a little look at the ECG, it just gives us a little peek into what the cardiovascular system is doing at that point. And if we've got any concerns, anything, the ECG trace looks a little bit funky, we can also let our friends in anaesthesia know if a patient needs to go for a procedure. So we can see here on Ralph's triage, his heart rate is 170 beats per minute. Obviously for a large breed such as Ralph, that is quite fast. We wouldn't really expect to see over sort of 120 for a large breed like a golden retriever. His tachycardia could be because of stress. He's just been in a car, he's arrived in a strange place. It could be because of pain, it could be because of blood loss, or it could be a low circulating blood volume, also known as hypovolemia. So we need to figure out what he's doing. At this point, his ECG says that he's in sinus rhythm. We'll also take a stethoscope and listen to the heart, because the ECG does not give us all information about what's going on at the heart at that point. And we hear that Ralph has a grade 2 heart murmur. So we already knew about that from the referring vet's notes. They found a heart murmur as an incidental finding just at a routine checkup, but he has not yet had a cardiac workup to see what the origin of that heart murmur is. So once we've finished our triage and we're happy, we'll send him to cardiology and they can perform a closer look to have a look at his heart. So respiration rate and effort, we can see his respiration rate is slightly increased at 60 and he's got a little bit of effort there. We look at his mucous membranes, they're quite pale and he has a prolonged capillary refill time of 2 to 3 seconds. So in a normal healthy dog, would expect to see nice pink mucous membranes and a CRT of about 1 to 2 seconds. Pale mucous membranes can be because of shock, as the blood is shunted away from the peripheral tissues to sort of the vital organs that need it, such as the liver, the kidneys, the brain. The body can do this because of trauma, it can do it because of blood loss or low circulating blood volume. Mucous membranes can also be pale where there is significant anemia. So that can be a result of blood loss or an immune-mediated condition such as immune-mediated hemolytic anemia, where they are breaking down the red blood cells. We feel Ralph's metatarsal pulses and they feel quite weak. This is our first indication that maybe he's got a low blood pressure. Feeling the pulses is really important in a number of situations. So in a normal healthy dog, we'd expect to feel sort of strong pulses. In an anemic patient, they can actually feel bounding or snappy as the body is really trying to pump that blood, the red blood cells around the body. It's working very hard. Or they can feel weak in a patient that's has got shock on board. So as I said, as ECC nurses, we're always feeling the pulses, so we can tell the difference. And we're really sort of eyes and ears for the vets when they're busy. So we can, if we feel pulses and we feel like something's wrong there, we can report that to the vets and they can investigate there. So we take a blood pressure reading on our oscillometric blood machine. We do also have Dopplers as well. We can see his blood pressure is a little bit low. He's got a systolic of 60. He's got a diastolic of 40 millimeters of mercury, and we've got a mean of 50. Obviously, we need to do something about that and investigate why he's got a low blood pressure. Prolonged low blood pressure can cause a problem to the body, can result in conditions such as acute kidney injury, and it means sort of inadequate blood perfusion to cells and tissues. So we really need to try and find why that blood pressure is low and find a way to get it up as well. We take Ralph's temperature and we see that he's a bit on the low side. He's got a core temperature of 36.5. We then place an IV. We take a little bit of blood out of the catheter for a blood gas. So if you're not really aware of blood gases here, it's basically like a minimum database. We use a machine called ANOVA. Just gives us an initial blood reading that we can work from to find out what's going on with Ralph. We also, because he is diabetic, we have a handheld glucometer and we just put a drop of blood on it just to see how his glucose is doing. At the moment he's not hypoglycemic, so we don't need to worry about giving a glucose bolus. So on our Nova machine, it's very similar to an iStat or, if you've worked in vets now, that kind of thing. It shows us a number of parameters that are very helpful when we're first admitting a patient, just to give a little window, a glimpse of what's going on. Takes about 30 seconds, so we can just put a bit of whole blood in and we get a reading very quickly. And also it shows us sort of what we maybe need to do initially to stabilise the patient. So a Nova reading shows us a glimpse into how the major organs might be working. So it gives us kidney and liver enzyme values. It also tells us his acid-base values, which can be quite important if we're looking at the pH of his blood, his base excess, his bicarbonate, and I won't go into too much detail because you could talk for hours about it, but just gives us a little glimpse into what's going on, whether he has a condition such as a metabolic acidosis, and various acid-base disorders are associated with certain conditions. That can be really helpful to know. Just as sort of a little a side note for people that aren't used to using blood gases, we are using a venous sample here. So it's going to show us a carbon dioxide reading, but it won't show us an oxygenation reading. For that, we would have to take a sample from an artery, which we do quite a bit in ICU as well. The Nova tells us his electrolytes, which is really useful, and it can tell us if we immediately need to supplement something, such as if he's got low potassium, we can put that on a constant rate infusion, as well as magnesium. If he's got low calcium, we may just carefully have to give a bolus of that. It can also help us guide fluid therapy as well, because if he has certain electrolyte derangements, such as sodium, we have to be really careful about what fluids we put him on and how we correct that, because if we put him on a saline drip and we correct that sodium too quickly, we can actually cause neurological disorders. So it's really, really important to get a baseline blood reading. The Nova also gives us a lactate reading, which is really important for patients who arrive to us quite critical with clinical signs of shock. And it's quite common to see this in the ECC department here. So we can see with, no, sorry, I haven't put it on there, but I've got it in my notes. Ralph's lactate is 5 millimoles per litre, which is above the normal reading limit of 2.5. We get an increased lactate when there's inadequate perfusion of oxygenated blood to cells and tissues. So basically, the lactate is sort of a byproduct of the cells creating energy in the absence of oxygen, also known as anaerobic metabolism. So the body can compensate for a while like this, but what we really need to think about is restoring that blood perfusion to cells and tissues, or we can start to see cells die off. We always take a PCV, also known as a packed cell volume, and a total solids, which we can do very easily manually in-house. This gives us important information about Ralph's hydration status, as well as whether he is anemic or not. So we can see here that Ralph's PCV is 15%. Sort of the normal reading for a dog is generally between 35 and 45%. So we can see that his PCV is low. His total solids are 90 and the normal reference range is between 60 and 75. So we can see that his total solids are kind of indicating that he's maybe a little bit on the dehydrated side, and also that his red blood cell count is low. So from our initial triage, we have gathered that Ralph he's a depressed mentation. He's got an elevated heart rate, he's got low blood pressure, he's got a low core temperature, he's got pale mucous membranes, he's got a prolonged capillary refill time, he's got an increased lactate reading, he's got a reduced PCV. So we've kind of got enough information here to establish that Ralph is probably in hypovolemic shock and that he may be losing blood from somewhere. So the first thing we usually do when we suspect a patient is in hypovolemic shock is we give them a fluid bolus. We need to try and restore that circulation blood volume, sort of pump up his blood vessels a bit and restore that perfusion of the oxygenated blood back to his cells and tissues. We usually use Hartmann's and we usually give a 5 to 10 ml per kilo bolus initially, and then we reassess his vitals and we can potentially give another one if it's working. We have to consider with Ralph though that he's got the slight sort of glitch that he's got a heart murmur. So we have to be really careful about what fluids we give him and what volume, because we could, if he has got underlying heart disease, we could potentially push his heart too much by suddenly restoring the blood volume. It can be too much for his heart. So what our vets do, our vets in ICU, we have our little ultrasound in ICU. What we always do with the patient is we perform a T-fast. So what that does is we pop the ultrasound on his chest and we have a little look into his heart, a very basic look into the heart, because as I said, we are not the cardiology team. But we have a little look into the heart and we perform what we call as an LAAO ratio. What that means is we look at the size of the left atrium, and if the left atrium is quite chunky, it usually means that there is quite a lot of fluid in there and it's not safe to give him a large volume of fluid at that time. So what we do with Ralph is we have a little look at the LAAO ratio and we see that the left atrium is quite underfilled. So at this point in time, we kind of have to problem solve, weigh up what do we do in the situation with a dog with a heart murmur, see the left atrium is underfilled. So we think at this point it's probably safe to give him a little 10 ml per kilo fluid bolus, and then we'll reassess from there. Nope, not there. So after 10 ml per kilo fluid bolus, we reassess Ralph's vitals. His blood pressure, his systolic blood pressure is increased to 100 millimeters of mercury. He's also brighter, he's starting to put his head up as we've restored that perfusion of blood. And so we're quite happy with that. So then the ICU vet also performs an AFAR, so that's very much the same, but we pop the ultrasound on his tummy. We just have a little look around the abdomen. We can, again, it's not a proper diagnosis, but we can have a little look at his abdominal organs. We can have a look at the size of the abdominal organs. We can measure them. It's got a little caliper device on it. And really importantly, we can look for free fluid. So we often look for free fluid in the abdomen with patients who have suffered from trauma, that kind of thing, because we're looking for things that are not supposed to be there, basically. So say we have a patient who's had an RTA, they could come into us, we can have a little look at the abdomen with the ultrasound and we can see that there's free fluid there. So the vet can pop a needle in, sample a little bit of fluid, and we can see what exactly that fluid is. So say if we've got a patient who's been hit by a car, if they've got free fluid, we could take a little sample and we could see that it's urine. And then we could have a look at the bladder on the ultrasound and we can see that maybe the bladder is ruptured. So we've got a uroabdomen. So what we see with Ralph is he's got a bit of free fluid in his abdomen. We sample it and we can see that it's blood. And then we have a little look at the spleen on the AFAST, and we can see it looks a bit abnormal. there's maybe a little structure on it. So we think there may be a splenic mass that could potentially be bleeding in there. So before we proceed to surgery, what we will do is after our AFAST, we will speak to our diagnostic care team, our diagnostic imaging team. They can have their super duper ultrasound, have an even closer look, and provide any details that we may not have seen. And then so exactly the surgery team go in and they would know exactly what they're looking for. Any kind of bleeding patient, we may take some more blood from them as well. We may look at their coagulation parameters just to check, are they bleeding because they've got a clotting disorder? So we'll do his in-house coags, which we've got all the machines here. We don't have to send anything off for that. And we'll also do just a very basic blood smear as well. We'll have a look at his platelets on a microscope slide just to see if there's anything going on there. So some masses can bleed really slowly, and some patients can actually cope quite well if it's a very chronic bleed. Especially patients who are chronically anemic, they do kind of adapt quite well, and they may have a sort of a low PCV sort of into every day-to-day life, but their body has learned to adapt. But the patients who present like Ralph, who are collapsed and weak and they've got changes in their vital parameters, that's more likely to be due to an acute bleed. So we have a number of different blood products at the Ralph here. It's a very large part of what we do in the ICU department, giving blood transfusions. I just gave one at like 9 o'clock last night. So we have a different supply of blood products here. So we have packed red blood cells, so that's where the red blood cells are concentrated. Specifically, we give those to replenish lost red blood cells in anemic patients, or if they've had quite a bit of blood loss. We've also got plasma, and that's where the plasma has been separated from the red blood cells for patients who are losing protein, perhaps if they've got a really nasty enteropathy, they may be losing a lot of protein, and we need to sort of bulk up that blood vessels. We give it quite a little bit in patients who are septic, which we also deal with quite a lot in ICU, and that's those patients, they've got vasodilation of their vessels, and they just cannot keep their blood pressure up, so we kind of bulk up the blood with some plasma. We also sometimes give platelets to patients who are thrombocytopenic. So we've had a couple of cases recently where we've had patients with a closed pyometra and they're thrombocytopenic. They really need to have life-saving surgery to get that uterus out. But we had the problem of sending them to surgery because they've got low platelets. So we may give them a couple of bags of platelets so they can have the surgery and not bleed out afterwards. We've also got cryoprecipitate. That is a substance that has really concentrated clotting factors such as fibrinogen, von Willebrand's factor, and we don't give it too often, but we typically give it to patients who have haemophilia. So we've decided in the ICU we're going to give a packed red blood cell transfusion to Ralph. We want to increase his PCV, it's currently low at 15%, but we also want to boost his blood circulation and overall just improve his condition before we send him to surgery. So we want to get him as stable as possible before putting him under an anaesthetic. We're going to give one 300 ml bag of packed blood cells, which equates to 10 mils per kilo, and we're generally going to give that over 4 hours. So a general rule of thumb, don't worry about this too much, but just to give you an idea, there are different sort of equations to work out how much you want to increase the PCV by. A general rule of thumb that we use is giving 1.5 mils per kilo will increase the PCV by 1%. But even if we increase the PCV by only a few percentages, it could make the patient feel so much brighter and so much better. So it's really important, and also to remember that he has an ongoing bleed in his abdomen as well. So say if we give 10 mils per kilo, we may not increase the PCV by 10% or 8% because he has this ongoing blood loss, but he in himself just may feel so much better. And it's also really important to remember with blood transfusions, because I said with patients who have a chronic bleed, they may come in quite bright-eyed and bushy-tailed. So it's really important when we're giving a blood transfusion that we need to remember the overall clinical picture of the patient, and that we don't just rely on the PCV. It's about whether the patient is dependent on a blood transfusion. That's how we look at the TPR. We see that are the pulses snappy, are the pulses weak, is the patient lethargic? So it's so much more than just the PCV reading. So before we give a patch blood cell transfusion, we need to blood type the patient. Another thing that we can do in-house very easily. So we need to know the blood type of the patient because we're testing for the dog erythrocyte antigen. Dogs are generally considered DEA1 positive or negative, but there are currently 8 recognised subgroups within those types, although there's thought to be whatever, depending on what literature you read, between 12 and 13 types. There's officially 8 at the moment. So in-house we cannot test for the exact type, but we generally test for the DEA1 positive antigen, which you can kind of see from this crude drawing here, that it's like little things that stick on top of the red blood cell. And the DEA1 antigen is typically the thing that gives them the most transfusion reactions. So most dogs are DEA1 positive, but negative blood is also really useful to have in-house, because in an emergency, we can give a negative blood transfusion to a positive type dog if the dog has not had a transfusion before. Dogs rarely have naturally occurring antibodies like cats do against other blood types. But if we test for the antigen, generally if we test for their blood type, it will make the transfusion more successful. It might last in the body longer than if we use a different type. So we blood type Ralph so that we can give him a type of blood that he's more compatible with, in the aim to reduce a blood transfusion reaction. We do this easily in-house with a blood type kit, just like this one. We only need a very small amount of whole blood. We mix it with some antigen and we'll get our reading within 10 minutes. So in the meantime, while we're running the blood type, he can go and have his echo with cardio. If he's had a transfusion before, we will need to run a cross-match test just to check that he won't have a reaction to the blood that we're going to give him. The blood type test tells us that Ralph is blood type positive, so we can grab a bag of that out of our blood fridge and we can start preparing it for him. We source our blood from Pet Blood Bank, so we do not have our own donors here. But on the odd occasion when we've only needed a little bit of blood, say we've performed a procedure like a pleurodesis, we have sometimes called on a staff pet for help in that situation. So we keep the blood in its own fridge. It has to be at a constant temperature. We don't put it in another fridge where it can get opened a lot, because blood is a great medium for bacteria to grow in. So we have to keep that as sterile as possible. When we're setting up the blood transfusion, we have to handle it all in a sterile manner, wearing sterile gloves. And when we're putting a blood transfusion giving set in, we have to do that all as sterilely as possible as well. Generally, when we're giving a blood transfusion, we have to flush the T connector as well. We have to make sure there's no Hartmans running alongside or in the T connector as well, as there are calcium ions in Hartmans that can actually react with the blood and form clotting. This is one of our monitoring forms here. So we'll do a pre-transfusion TPR. We'll start the transfusion off slowly for the first half an hour. We'll give him a small amount, usually 0.5 ml per kilo. We'll give that very slowly because we're going to be looking for any reactions within the first half an hour. We generally have a multi-parameter on the patient at all times. We have a dedicated nurse who's monitoring them constantly, and we'll be looking for any signs of a blood transfusion reaction. So there are lots of different types of blood transfusion reactions that I have not got the time to go into detail here at all, but I'll give you a general guideline of generally what we're looking out for when we are monitoring a blood transfusion. We're generally looking for signs of change in the TPR. That's why we have to keep such a close eye. We're looking at, is there a change in the heart rate? Do they become tachycardic? We're looking at a change in the temperature. Generally, if they sort of spike a fever. We're looking at the respiration rate and effort. And we're looking for signs such as vomiting and diarrhea. So we really have to keep such a close eye on these patients whilst they're receiving a transfusion. If sort of within the first half an hour the transfusion seems to all be going swimmingly, I'm so sorry. If all seems to be going fine within the first half an hour, what we'll do is we'll increase the transfusion. We'll generally give them sort of 4 mL per kilo per hour over the rest of 3.5 hours. So I'm just going to I've got no time left, but what I'm going to do is I'm generally going to just give you a very quick overview of the types of transfusing reactions that we're looking for, and you can also research it in your own time if you like. So these can be either immune system responses or outside of the immune system. So we've got hemolytic, generally when the body is breaking down the red blood cells. This can be both an immunogenic response or a non-immunogenic. We've got a septic reaction. That's typically when the blood has been contaminated with bacteria, and we are actually looking out for signs of sepsis in the patient there. So they spike a fever. They can have low blood pressure. So we may need to stop the transfusion in that instance. We may need to give the patient antibiotics and supportive therapy. We're also looking for hypersensitive reactions. So that can be quite mild, or it can go as badly as anaphylaxis. We can be looking at vomiting, diarrhea, even hives, itching. We may need to slow down the transfusion, or we may need to stop it and give something like chlorphenamine and antihistamine just to stop that reaction from happening. We've also got febrile reactions, and that's typically when the patient spikes a fever, but we've kind of ruled out all the other reaction types. And it can be a reaction to other substances in the blood as well, such as proteins and cytokines, things like that. We've also got TACO, is essentially transfusion associated circulatory overload, where the patient has received too much volume than it can handle at that point. That can happen if they've got underlying heart disease. So typically it presents as fluid overload, so they may get dyspnea, and we may need to give them some diuretics in that case just to get rid of some of that fluid in their body. And we've also got TRALI, transfusion-related acute lung injury. This is actually considered quite a rare reaction, but I think I have seen this in the ICU here, and that's when a patient can go dyspneic, tachypnic, and can go hypoxemic as well. We have to stop the transfusion. We may have to give some oxygen. And this is diagnosed when the patient had no previous lung injury. So it's really important to look out for reactions. Luckily, Ralph does well in his transfusion. Most of the patients do. And that's it for the ECC department at the moment. And so there's a lot to go over in 30 minutes, but I hope that just provided a little bit of an insight into what we do. Okay.